I want to thank my close friend Uma Devi Madam for giving me this opportunity to share my thoughts about breast lesions. And I know you are all waiting on the online, and I am few minutes late. Sorry for that. So, after a brief introduction of breast, we will go through the spectrum of breast lesions, and I will touch the WHO 2019. And rather than concentrating on that, I want to concentrate on practical classification of breast lesions. And I want to tell the criteria for common epithelial breast lesions. When you have to diagnose DEH, ductal epithelial hyperplasia, when you have to call it ADH, when do you want to call it DCIS? It's more like a histologically, morphologically, criteria-based discussion. And then I want to touch upon immunohistochemistry that is useful in the differential diagnosis of breast lesions. And none of the talks are complete without telling about molecular events. There are so many things that are happening, but I will tell what are all the proven molecular events in breast lesions very briefly. And I will end it up with some take-home message, and I will give you some references so that you can go through them. Breast lesions can be classified clinically, radiologically, and pathologically. Clinically, they can diagnose only palpable lesions. The non-palpable lesions can be diagnosed only by radiologists and pathologists, and the reason is obvious. If it is not palpable, clinician won't be able to see it. And the palpable lesions are classified into well-defined or ill-defined, solid, cystic, mixed solid and cystic, and most importantly, whether the breast swelling is mobile or fixed. Usually it is mobile means benign and fixed means malignant clinically. So, and another clinical presentation is the nipple discharge, and the nipple discharge can be milk-like, hemorrhagic, or like serous fluid. Depending upon the nature of that, we have our own differential diagnosis. Radiologically, the lesions are classified into palpable and non-palpable. Okay, and these non-palpable lesions are identified with calcification or without calcification, and this is a lesion with calcification which may not be palpable. And the palpable lesions radiologically can be divided into solid, cystic, mixed solid and cystic. And how do we traditionally classify breast lesions? Usually we divide any classification, any organ. The traditional classification is non-neoplastic and neoplastic. In the non-neoplastic, it is congenital, traumatic, inflammatory, fibrocystic changes in case of breast. And neoplastic, the main classification is whether it is primary or secondary. This is the very, very important question, because if it is primary, it is a local disease. Surgery is the treatment. If it is secondary, it is a systemic disease. Chemotherapy is the treatment. That you have to remember. And in the breast, the neoplastic lesions are classified into epithelial, stromal, and mixed and others. So this is the pathological classification. So now you can see how the disease can be approached clinically, radiologically, and pathologically. And WHO, this is the, I cannot say recent, but this is the edition available now, 2019, 5th edition breast tumor. And it divides the breast lesions into 7 major categories. Epithelial, that includes myoepithelial also, fibroepithelial and hematomatous, tumors of the nipple, mesenchymal tumors, hematolymphoid tumors, tumors of male breast, and all the recent WHOs, they are having a genetic tumor syndromes. Just to know the names of them, don't try to memorize the genetic tumor syndrome. Just know the name, and if you read 2-3 times, then it will stick to your mind. Pathology is a beautiful subject, but you have to read at least 3 times so that you can keep it in your mind. And if you memorize, it is not humanly possible to know everything. So whatever you are reading, you have to apply, or whenever you want to apply, you read so that you will remember. And we will be mainly talking about epithelial lesions. So how to approach practically the breast lesions? 4 questions you have to ask yourself: whether the lesion is proliferative or non-proliferative, whether the cells are showing atypia or not, whether the cells are coming out of the basement membrane, goes into the mesenchyma that we call invasion, and is there any metastasis. So these are all the 4 questions you have to ask. And depending upon the answer, the lesions can be classified into non-proliferative diseases, proliferative diseases without atypia, proliferative diseases with the atypia but no invasion, proliferative diseases with the atypia with the invasion but no mets, and lastly proliferative diseases with the atypia with the invasion with mets. I want all of you to take a snap of this. This is the major 5 types of classification of lesion in any organ. This is a pattern based approach, okay, and this is going to replace all the classifications. This is very nicely done in breast and all the organs. Pathologically, practically, to diagnose, you have to classify them into 5 of these types. And within this type, for example, non-proliferative disease, you can make mistake. You can call ductectasia into acute mastitis. Nothing will happen. Whereas you cannot cross the boundary. You cannot proliferative disease with no atypia. And I will show you some examples. It will show non-proliferative disease, cysts and mammary ductectasia. Proliferative diseases without atypia is ductal epithelial hyperplasia, which can be moderate or florid, sclerosing adenosis, intraductal papilloma, any inflammatory. Even in inflammation, it is proliferation. It is proliferation of inflammatory cells, okay, and it's divided into non-granulomatous and granulomatous. The example of non-granulomatous in breast is lactation mastitis, subareolar abscess, and most commonly, which is underdiagnosed in India, is lymphocytic mastitis, which is very common in diabetic patients. And in the proliferative disease with the atypia, no invasion, there are borderline lesions and carcinoma in situ. And what do you mean by borderline lesion? Atypical ductal hyperplasia, atypical lobular hyperplasia, atypical papilloma. These are all not ductal epithelial hyperplasia, and they are not DCIS or LCIS. Okay, so they are in the borderline. Carcinoma in situ is divided into DCIS and LCIS. And proliferative disease with atypia with invasion, depending upon the distance of invasion, you classify them into invasive, micro-invasive, and invasive. In breast, the criteria is 1 millimeter. If the invasion is less than 1 millimeter, it is micro-invasive. If it is more than or equal to 1 millimeter, then it is invasive carcinoma. And whenever there is invasive carcinoma, next question, is there any metastasis? Okay, so whether it is lymph node metastasis or systemic metastasis. I want all of you to take a snap of this. So these are all the examples of pattern analysis. Okay, so you ask yourself, is there any proliferation? Is there any atypia? Is there any invasion? Is there any metastasis? Depending upon that, we have these 5 columns of classification. And within the column, you can make difference. For example, lobular carcinoma, ductal carcinoma, no much difference. But you should not be missing lobular carcinoma and calling it as fibrocystic changes. I hope you all understand how to classify. And most of my talk will be regarding this practical classification of breast diseases. Why we have to know the spectrum of breast lesion? What is the spectrum? It is normal, physiological changes, non-proliferative, proliferative without atypia, proliferative with atypia, carcinoma in situ, microinvasive carcinoma, carcinoma with mets in lymph node, or systemic. Once it comes carcinoma, we can't, as a good doctor, you have to prevent the development of cancer. Okay, that should be our aim. There is no point of diagnosing cancer. The minute you diagnose cancer, you are not able to reverse it. Okay, so the reversible causes are proliferative lesions without atypia, and it has a 2 times risk of malignancy, whereas when there is atypia, the risk increases to 5 times, and when it is carcinoma in situ, the risk increases to 10 times for the development of subsequent cancer. So we have to identify lesions at this level, and we have to prevent the patient developing going into this invasive carcinoma level. That's why you have to know the spectrum of breast lesions, so that you can prevent the development of cancer by screening the patients and identifying the breast lesions in the pre-invasive status. What are all the samples you may get in the lab from breast? Okay, it can be 5. Number 1, FNAC. Number 2, core biopsy, which can be guided or blind. 3 is needle localization biopsy, 4 is excision biopsy, and 5th one is intraoperative frozen section and radical surgery, depending upon the finding. You please include radical surgery here. So there are 5 types of specimens. Here you can see a very nice FNAC, very nicely made smear, and these are the core biopsies, and this is the excision biopsy. Okay, this localized needle localization with the excision. And how to avoid whenever you are taking FNAC or core biopsy, the initial pathologic diagnosis should correlate with the final excision. For example, you call it core biopsy carcinoma. They removed breast by radical mastectomy, and radical mastectomy specimen should have carcinoma. Okay, and is it 100% happening like that? FNAC and core biopsy, we may miss some of the carcinomas. We may call it benign, but the patient may have malignant, and that's where the word triple test comes. Triple test is very popular in breast, but my kind request is use this triple test in all the organs where pathological, clinical, and radiological findings should go hand in hand. If they think cancer clinically, radiologically, it has to be cancer pathologically. Okay, if any one of them is discordant, for example, radiologically they tell it is cancer, pathologically you don't see cancer, that means you have to go for further investigation or excision. And whenever there is any discordancy, there are 3 reasons. One is sampling error. Imagine this, they are going to do FNAC. If they do FNAC here, they have not touched the lesions, whereas here they are overshoot the lesion. Okay, so they are sampling in this here area, whereas tumor is here. So this is known as sampling error. Second one is interpretation error, and it is on the pathology part. Okay, for example, it is a complex radial scar. I diagnosed it as complex radial scar, but the patient further subsequently developed carcinoma. I go back and I miss the tubular carcinoma in the complex radial scar. It is the interpretation error. And third is nature of lesion. They do a mass in the breast, they do FNAC, and it is negative, but clinically they thought malignant, so they went for excision, and it is a lobular carcinoma in the excision. Why we missed lobular carcinoma? You all know these are all single cells arranged in a targetoid pattern and tightly embedded in a fibrotic stroma. And when you are doing FNAC, these tumor cells may not come out during the FNAC. Okay, you may get it in the core biopsy or excision, but usually they won't come in the classic lobular carcinoma. So that is known as nature of lesion. So this you have to remember. Whenever there is a discordancy, whether it can be due to sampling error, interpretation error, nature of lesion. If it is sampling error, we can educate the people who are doing the procedures. For example, radiologists in core biopsy or pathologists in FNAC. Interpretation error, it is on our part. And nature of the lesion, both can be right, but we may be missing this lesion. So treatment options based on biopsy diagnosis, it can be careful follow-up. For example, fibrocystic changes, follow-up. Excision, atypical ductal hyperplasia, radical surgery in cancers without metastasis. And when it is metastasis, preoperative or postoperative radio, chemo, and hormone therapy. But surgery is the mainstay in breast cancer. Okay, keep that in mind. And radiation, chemotherapy, or hormone therapy in advanced stages, or whenever the prognostic factors, for example, ERP are positive, we may add this. But stage of the disease determines whether they need chemotherapy or hormone therapy. In any organ, you have to know the normal histology. Then only you can diagnose the lesions arising from normal histology. In the breast, there are mainly 6 to 10 major ducts, and that goes into terminal ducts, ductules, and acini. If you start from acini, acini drain into ductules, ductules come to terminal ducts, and terminal ducts come into lactiferous duct. And if you take this is the lobules, breast lobules, okay, and they are all arranged in a lobular pattern. This pattern is very, very important, and when this pattern is maintained, it is benign. Whereas in malignancy, this pattern is lost. Okay, and these are the acini. Some ducts are coming there, and this is the one of the terminal ducts, and these are ductules. Terminal duct that goes into lactiferous ducts. And when you see it in high power, the acini as well as the ductal structures are lined by two layers of cells, okay, luminal cuboidal to columnar cells and abluminal or towards the basement membrane round or flattened cells with vacuolated cytoplasm. I hope you all appreciate the two types of cells. This is very, very important. The luminal cells are known as secretory cells, and the abluminal cells, whenever the breast secretes milk, somebody has to express it, okay. So the myoepithelial cells contract. Imagine these are myoepithelial, muscle and epithelium. So the muscle part contracts and pushes the secretions into the ductules. So these two layers of lining epithelium is very, very important to understand. Whenever there is more than two layers, then it is hyperplasia, minimum hyperplasia. Okay. So, and this myoepithelial and epithelial relationship is lost in malignancy. In case of malignancy, it has to be either epithelial proliferation or myoepithelial proliferation. There are only very few rare conditions where you see both epithelial and myoepithelial proliferation. In a breast cancer, epithelial cancer, you should not see the myoepithelium. That is very, very important. And immunohistochemically, the secretory cells are positive for low molecular weight cytokeratin, whereas the contractile cells, myoepithelial cells, are positive for high molecular weight cytokeratin and P63 and its cousin P40. Okay, the special, I will be showing the slides, and even here you can see the slides. These are brown colored, the brown colored one are the myoepithelial cells. They are staining the nucleus. Okay, so this is P63, whereas the ductal epithelial cells are here, they are stained red color in the cytoplasm. These are low molecular weight cytokeratin 7. Okay, low molecular weight. So this epithelial myoepithelial relationship is very, very important. Another thing you have to remember, there are two types of stroma. Okay, there is a stroma within the lobule and stroma outside the lobule. Okay, so this is intralobular stroma, whereas this is interlobular stroma, which is more collagenized. The intralobular stroma is more edematous and it gives some space. Why it is there? Because if the patient become pregnant, the milk has to be secreted, so the acini will slightly enlarge in size. So God created some room for the enlargement of the acini within the lobules. That's why there is a difference between intralobular and interlobular. Why we have to know? Because there are certain tumors that arise from intralobular stroma. For example, fibroadenoma, phyllodes tumor, they arise there. Whereas some tumors arise in interlobular stroma, fibromatosis, leiomyoma, they happens in the interlobular stroma. That's why you have to understand the intralobular and interlobular stroma. This normal histology is very, very essential. What are the physiological changes? It can be pregnancy, lactation, or cessation of lactation. Okay, in pregnancy and hyperprogesteronism, what happens? The cells become hypersecretory, they are many vacuolated and they are ready to secrete. What happens in lactation? All the secretions are come out and the cells are there exhausted after the secretion, and they will have the hobnail pattern with less amount of cytoplasm and nuclei in the periphery of the cells, because all the secretions are gone into the lumen. This is the lactational change, which you see it in adenoma, and that is called as lactational adenoma. After cessation of lactation, what happens? There is incomplete lobular regression. They never go back to normal, but they are incompletely regressed. What happens in postmenopause? After the function is done, there is atrophy of the acini. And if you imagine, the inter and interlobular stroma is different in reproductive age group, whereas perimenarche and postmenopausal, the distinction between the interlobular and intralobular, they look alike. Okay, so by looking at the H&E section of the slide, you can roughly say whether they are reproductive age group or postmenopausal or premenopausal. Okay, and we are like Sherlock Holmes, the pathologists. Okay, we see things what are happening and we give evidence-based diagnosis. Okay, that evidence-based diagnosis is very, very important. For that, you must use the word criteria. Coming to proliferative disease without atypia, let us start with the inflammatory lesions. acute mastitis, okay, which is very common during lactation, and it breast shows signs of inflammation. Usually it is due to Staphylococcus aureus or Streptococcus, but they are rarely biopsied. Who biopsies acute mastitis? It is a clinical diagnosis, and you make the diagnosis. Nobody take the biopsy, but when they take the biopsy, it will have a lot of neutrophils and debris. And here I am cheating you. This is not from the breast. This is from some other organ. So this is a prostate. Okay. The learning from here, nobody does biopsy for acute mastitis. Subareolar abscess is a different story. Okay. What happens here? It is normal. Okay. The normal duct having a lining epithelium. The terminal portion of the duct is lined by squamous epithelium. What happens sometimes? There is a keratin plaque that obstruct the duct. Okay. And all the secretions are accumulated and they are not able to come through the normal pathway. So they create their own pathway. Okay. So, and this happens in the subareolar area. And this is the fistulous opening at the area. Here you can see the subareolar abscess. And when they any breast lesion, they first do FNAC, isn't it? In FNAC, you see a lot of keratin plaque and neutrophils. Okay, so that's the criteria for subareolar abscess. Number one, anatomic location. Number two, FNAC should show neutrophils and squamous cells. When you see neutrophils and squamous cells, you have to diagnose subareolar abscess. Okay, and this keratin in histology, they may produce some granulomatous reaction. You may say even in FNAC, you may get some granulomas, but be aware of it. Anatomic location clinically and presence of squamous cells, neutrophils. Even when you see granuloma, you have to think of subareolar abscess because TB is the most common in our country that produce granuloma. But when you see squamous cells, you have to think of keratin and it can produce foreign body type of giant cell reaction. The another condition is mammary duct ectasia. Ectasia means dilatation. This happens in the major ducts. They are not only dilatation of ducts, there is chronic inflammation and they should have increased number of plasma cells. That's the one of the criteria. So the criteria for mammary duct ectasia, major ducts, ductular dilatation, chronic inflammation with the inspissated secretions, and that chronic inflammation should have plasma cells. This is the criteria. I hope you all follow what is the criteria. For everything, you should have criteria. Fat necrosis. This is a very, very important thing because fat necrosis will look like malignancy clinically and radiologically. We are the only people who give good news. Okay, and this fat necrosis happens following trauma, surgery, or radiation, and they are very ill-defined. Grossly, they may show bright yellow or ill-defined mass, but microscopically, it has characteristical depending upon acute or chronic. In acute, it shows necrotic fat and macrophages and neutrophils. Okay, whereas in chronic, it will start showing foreign body giant cell reactions and fibrosis. Okay, so the fat necrosis is a very, very important pathological diagnosis. The lymphoplasmacytic mastitis, which is underdiagnosed in our country, I hope you all will look specifically, see the lobules. Okay, and the age of the patient is not reproductive age group because the intralobular stroma and interlobular stroma, they are more or like same. And you see lymphocytic infiltration in the lobules, and you see in the stroma, they show keloid-like collagen. Okay, and when you see it in high power, this keloid-like collagen may show atypical fibroblasts. These three are the criteria for lymphoplasmacytic mastitis, which can be seen in diabetes mellitus or other autoimmune disorders. Okay, AI is autoimmune, not artificial intelligence. Okay, so in diabetic mastopathy, periductal or perilobular lymphocytes, keloid-like fibrosis, and atypical scattered fibroblasts. These are the three criteria for diabetic mastopathy. When these lymphoid aggregates are extensive and they go into the fat also, producing paniculitis, you have to think of lupus mastitis. Okay, ask the clinical history. Okay, and Subhashri or my PGs will be knowing whenever I am seeing breast biopsy, when they have lymphocytes in the lobules, I always check their sugar level and the serology for any autoimmune antibodies. Okay, and 90% of the time they will have abnormal sugar value. Okay, that is very, very important to diagnose. And why you have to pay importance to lymphocytic lobulitis. They are usually associated or BRCA1 associated tumors. In the background, they may show lymphocytic lobulitis. Okay, whenever in a core biopsy you see lymphocytic lobulitis in a mass lesion, think of BRCA associated, what we used to call medullary carcinoma. Okay, now medullary carcinoma in the recent 2019 WHO, it is not used. It is a infiltrating breast carcinoma medullary pattern, that separate entity is not there. And they will have a pushing margin, intratumoral lymphocytes, central necrosis, and IHC is triple negative. These are all the features for infiltrating breast carcinoma with the medullary features. And why you have to know that? They are associated with BRCA1. And number two, because of the intratumoral lymphocytes, and this is the another concept you have to remember. Whenever there is increased number of lymphocytes within the tumor, they will respond to PD-1 and PD-L1, anti-PD-1 and PD-L1. Okay, we pathologists, we play a major role in deciding which patient will respond to targeted therapy. And please remember, any organ, any tumor with increased number of lymphocytes, okay, for example, lymphoepithelioma like squamous cell carcinoma, this medullary carcinoma, they will have a very good response to anti-PD-1 and PD-L1. Because these lymphocytes are keeping quiet themselves against the tumor because of the blockage, PD-1, PD-L1 blockage. So if you remove the blockage, the lymphocytes will take care, kill the tumor cells. Granular metastasis, you all know, necrotizing and non-necrotizing, that is the major classification. And whenever it is necrotizing, it is mainly infection, for example, TB or fungus. Whenever it is a non-necrotizing granuloma, it is an immune mediator like sarcoidosis. And as I told before, even fat necrosis can produce some giant cell reactions. Fibrocystic changes, you all know, previously it is called fibrocystic disease, but it is present in almost all the females in reproductive age group. That's why they don't want to call it as disease, and that may be due to hormonal imbalance, and it varies phase to phase in the menstrual, depending upon the menstrual cycle. And the heterogeneity is very important. See the small, mildly dilated, maximum cystic, dilated cystic space. This is of varying sizes and shape. This is very, very important. Probably I will tell. Yes, cysts. And even polymorphic pathology. Polymorphic means it's not a uniform appearance. Okay, even you see here the blue dome cyst, isn't it? So that's the breast gross pathology in autopsy study, because nobody does excision for fibrocystic changes. And as the name shows, it shows fibrosis and cystic changes, increased number of glands, epithelial hyperplasia and metaplasia, and they are usually associated with intraglandular calcifications. That polymorphic appearance is very, very important to diagnose fibrocystic changes. The next disease is sclerosing adenosis. The lobularity is maintained. That is very, very important to remember. But within the lobules, the glands are increased. That's why it is adenosis. And the intralobular stroma is sclerotic. That's why it is sclerosis. Okay, sclerosing adenosis. Okay, lobularity maintained with the increased number of acini distorted by sclerosis. When you do the myoepithelial marker, remember in normal histology, I told myoepithelial cells are preserved in benign. See here, all the myoepithelial cells are preserved by immunohistochemistry. Okay, so this is a and the lobularity is maintained. And another thing in sclerosing adenosis, DCIS can involve sclerosing adenosis. LCIS can involve sclerosing adenosis. Cancer can involve sclerosing adenosis. So whenever you see sclerosing adenosis, look for carefully whether it is any in situ or infiltrative cancer involved in the sclerosing adenosis. As I mentioned, the lobularity and preserved myoepithelial cells will help you in the correct diagnosis of sclerosing adenosis. Okay, and this is a sclerosing adenosis with apocrine metaplasia. Okay, this looks like apocrine carcinoma, isn't it? But when you do the myoepithelial marker, all the ducts are lined by myoepithelial cells. Okay, that's why it is a benign diagnosis. Coming to the next interesting thing is complex radial scar. Now it is renamed as complex sclerosing lesion. There is no much difference, but they keep changing some of the names and they may have valid reasons. Okay, so Clinically, radiologically, light fat necrosis, it will resemble carcinoma. Okay, radiologically, you see, I labeled this as CRS and a C cancer. That's why I'm able to differentiate. Otherwise, radiologically, both looks alike. Okay, grossly, it looks alike. Okay, but microscopically, it is very different. Okay, so it shows a central sclerosis with radially arranged glands. And one of the clue here is in the radial arrangement of the glands, as they come to the periphery, the glands increases in size. This is a very, very important clue in H&E sections. Okay, so centrally the glands will be small in size, but as they come to the periphery, they increases in size. This you have to remember. The differential diagnosis is tubular carcinoma, especially in the central area where there's a lot of sclerosis and the glands are small in size. They may look like tubular carcinoma, especially in a core biopsy. But when you do P63 or P40, the complex radial scar will have myoepithelial cell, whereas tubular carcinoma should not have the myoepithelial cell. Another interesting condition that can be misdiagnosed as tubular carcinoma is microglandular adenosis. Okay, it's a benign round glands. They are round glands. And why it is mistaken for cancer? Because they are infiltrative. The lobularity is not maintained. This is the only condition where the lobularity is not maintained. I remember I told you the lobularity has to be maintained in benign conditions, isn't it? Whereas in microglandular adenosis, they will show infiltration. And another thing is they won't have myoepithelial cell. Because of these two, microglandular adenosis is very important to remember. They are infiltrative and they don't have myoepithelial cell. But when you look carefully, they are all round glands, okay, and they will have some eosinophilic secretions. They will look like thyroid. Okay, when you look like thyroid in a breast, think of microglandular adenosis. So here, can you see? So these are all the microglandular adenosis. And I told you myoepithelial cells are absent. So by doing P63 or P40, you should not mistake it as cancer because myoepithelial cells are absent. But luckily, all these cells are strongly positive for S100. Okay, please remember microglandular adenosis S100. They are strongly positive for S100. And even though the myoepithelial cells are not present, they have the basement membrane. So when you do laminin or type 4 collagen, the basement membrane will be highlighted. Whereas in cancer, basement membrane should not be there. And usually the breast cancers are negative for S100. So if you are having a DD of a tubular carcinoma with microglandular adenosis, use the S100. Previously, it is thought it's a benign condition, nothing to worry. But now they know some of the tumors are arising from the microglandular adenosis, and most of these tumors are triple negative. So they have a spectrum now: microglandular adenosis, atypical microglandular adenosis, and carcinoma, which is usually triple negative. Most of them are metaplastic type of carcinoma, or they develop salivary gland type of acinar cell carcinoma. Okay, these are all the two carcinomas that are associated with the MGA or microglandular adenosis. And molecularly, they have proven they have the same molecular signature in the triple negative carcinoma and the precursor MGA. So now the microglandular adenosis is a precursor, and this is a classic microglandular adenosis. This is a nice table, but pay more attention to the starred areas. Okay, when do you call atypical? When the glands are variable in size and shape and they show solidness, or the glands are fused. Okay, whereas here the glands are single, they are not fused, and they have eosinophilic secretions. Whereas when they get solidness and fusion of the glands, you have to think of atypical microglandular adenosis. And when there is invasion, these are all the microglandular adenosis glands, and you see the invasive carcinoma here. This is the triple negative carcinoma associated with microglandular adenosis. So please remember the microglandular adenosis is a precursor lesion. So we saw some interesting sclerotic lesions: sclerosing adenosis, complex radial scar, microglandular adenosis, and they are usually confused with the tubular carcinoma, which is a low-grade carcinoma. So this table helps you to differentiate these conditions. And whenever you have differentials, you first look into the microscope in the low power. okay, and then high power. Then use immunohistochemistry or histochemistry. That approach is very, very important, and that's how I will be giving all the tables in the differential diagnosis. Okay, the lobular outline is maintained in adenosis and complex radial or complex sclerosing lesion, whereas there is an infiltrative pattern will be seen in microglandular adenosis and tubular carcinoma. Glandular size and shape, they are very variable in sclerosing adenosis and complex radial scar, and remember the cysts are more larger in the periphery, whereas the glandular size is uniform in microglandular adenosis and tubular carcinoma. In microglandular adenosis, it is rounded, whereas in tubular carcinoma, it is angulated. Intraluminal secretions very prominent in microglandular adenosis, and the stromal desmoplastic reaction is there in tubular carcinoma. This is the low power, and I have given a picture of sclerosing adenosis, complex radial scar. This is the microglandular adenosis with the secretions, and this is the tubular carcinoma. Okay, see the angulated glands and the desmoplastic stroma. Coming to the high power, the lining epithelium, you see both luminal and myoepithelial cells in sclerosing adenosis and complex radial scar. I'm using the terminology complex radial scar, but remember it is now known as complex sclerosing lesion. Wherever it is CRS, you have to see complex sclerosing CSL now. In microglandular adenosis and tubular carcinoma, it's only luminal cells. The myoepithelial cells are absent. Look for the apical snouts. Here you can see very nicely, which is very commonly present in tubular carcinoma. And cytological atypia will be present in tubular carcinoma, but it is low-grade cytological atypia. Sometimes it's difficult to differentiate. So that point may not be very helpful. Okay. So this is a classic example of sclerosing adenosis, complex radial scar, microglandular adenosis, tubular carcinoma, and tubular carcinoma in high power that shows apical snouts. Okay, angulated glands with apical snouts and desmoplastic stroma are characteristic of tubular carcinoma. Coming to immunohistochemistry, the basement membrane, okay, it is present in all benign sclerosing adenosis, complex radial scar, microglandular adenosis, whereas it is absent in tubular carcinoma. And the myoepithelial cells are absent in MGA and tubular carcinoma. So please remember, MGA is the only benign condition where P63 will be absent. In sclerosing adenosis, you can see the nice nuclear staining for P63. Highlighting the myoepithelial cells, whereas in tubular carcinoma you don't see them. Adjacent some normal ducts or hyperplastic ducts will have myoepithelial cell, whereas the lesional glands are not having the myoepithelial cell.